My name is Bill Boro. I'm a chiropractor in Annapolis, Maryland, certified SOT craniopath. Presentation today is treatment of low back pain by cranial adjustment. Let's see if I can figure out this one. Most people, I assume, are familiar with the basic anatomy of the skull. Low back pain is obviously something that, as chiropractors, we treat every day. This case report is to examine the clinical connection between lower back pain and cranial disc relationships. Had a patient present to my office. He's a policeman, 39 years old, weighs 275 pounds, 5'9", a little overweight. 3 or 4 years previous to his visit to my office, he had been in an altercation with a suspect. He had to subdue him and then lift the man up on a stretcher into an ambulance. And during the process of lifting him up on the stretcher, his low back went out, injured himself, and then received some physical therapy for that. The low back pain resolved itself for the most part. About a year ago, July 2011, he was involved in a second altercation with a different person and injured his knee in the process. So from last July until this spring, he had the knee injury. His low back pain began to come back periodically, and he was scheduled for knee surgery. So in March of this year, they had knee surgery on his, I believe, his right knee. And as soon as he recovered from the surgery, his low back pain came back with a vengeance. It was constant, unremitting, and he was very unhappy, needless to say. He came to my office. As a result, I'd been treating his wife successfully, so he appeared in my office and was at the same time, and still is, receiving physical therapy for his knee to recover from the surgery. So during the exam, he stated that his knee pain was 4 out of 10, and that was in both knees, not just the knee that was operated on, but his other knee as well. Low back pain on flexion was 5 out of 10. Posturally, a low right hip, low right shoulder, and his ear was low on the left. Had a positive Trendelenburg on the left side. Left arm fossa was tested positive in the upper fossa. And on spinous pressure along the spine, there was pain and discomfort at L5. I also performed a series of muscle tests. These aren't all of them, but I listed all the ones that were 4 out of 5 in terms of strength. Transverse abdominis was a 4, +4. Psoas major was a +4. Adductor brevis was a +4. Gluteus maximus was a +4. Multifidus was a +4. Iliocostalis lumborum was a +4. Bilaterally, all these were bilateral. Sternocleidomastoid was also a +4 bilaterally. Splenius capitis was a 4+ bilaterally. The gluteus medius was a +5 bilaterally, as was the rectus femoris in his leg, and probably 1 or 2 other muscles I don't remember, but nonetheless, these were all +4 at the initial examination. The methods of analysis and adjustment that I used for chiropractic treatment are based on Dr. Richard Van Rump's research, as opposed to SOTO and SOT analysis. And for those of you who are unfamiliar with Dr. Van Rump, he and DeJarnette met in the late 20s of the last century and became close friends, and Dr. Van Rump became a student of Dr. DeJarnette's, and they cooperated together for about 20 years. Van Rump was selected to be the research director of the East Coast for SOT at that time, and was so for the next 20 years. But Dr. Van Rump developed his own techniques of analysis using a foot-leg reflex. So basically, you start off with even legs, and if a patient has an anatomical short leg, you'd put a heel lift into the short leg side so that the actual legs are even when you start. And on equal aversion of those heels, there's a certain axis of rotation, at the subtalar joint that you attempt to achieve in your mechanical movement of these feet. And you start off with equal aversion, and if you underrevert one side and overrevert the other side, you will get a shortening that appears in the other leg. As a result of that, you can then use it as a feedback tool and challenge the patient's body, and checking that reflex response, either identify that there's a subluxation one direction or another direction. So Van Rump's analysis is fairly simple and straightforward. It's a strictly spatial, three-dimensional analysis, as in a Cartesian axis. You would look for patterns. He found 3 patterns: an anterior, a posterior, and a mixed pattern where one side is anterior, the other side is posterior. And then occasionally you'll find people where they have no real pattern, just an individual bone, or some of the bones that just don't follow any of the patterns. All familiar with the skull. So you need to test each bone in the skull to identify the subluxation pattern of that bone. You start off with the sphenoid bone as your indicator bone, and you would test it for anterior subluxation or a posterior subluxation, superior subluxation or an inferior subluxation. And if it was a different bone, you would also test whether it was medial or lateral in its subluxation positioning. So if you identified your sphenoid bone as being anteriorly subluxated, then based on the results of many patients, you can assume that there is an anterior pattern. Although you wouldn't make that assumption because you would test each bone individually, but the anterior pattern consists of an anterior superior sphenoid, an anterior superior temporal bone, and an anterior inferior mandible. To correct those bones, the subluxations, you would adjust them in the opposite direction. So if the sphenoid is anterior superior, you would apply a thrust to the posterior inferior direction. For the temporal bone, a posterior inferior thrust. Actually, thrusts for the temporal bone are in several locations, 2 locations. And for the mandible, posterior and superior. If it was a posterior subluxated sphenoid, again, the sphenoid would go posterior inferior. And you would have the same kind of pattern for the temporal bone and for the mandible. To correct it, you would adjust them in the opposite direction. The sphenoid would be adjusted anterior superiorly. The temporal would be adjusted anterior superiorly, and the mandible would be adjusted posterior inferiorly. Anterior inferiorly, rather. The facial bones also would be subluxated. You would analyze the frontal bone, the nasal bones for superior inferiority and right or left laterality. The zygomatic bones also for superior inferior and medial laterality. The maxilla for anterior, can't work the buttons. For superior and inferior, and for medial or lateral for each of the maxilla bones as well. Also, one would analyze the parietals and the occiput. The parietals would be medial or lateral, each one, and also anterior posterior. Oftentimes these bones, there's actually a shearing effect that is found. For the occiput, again, analyze for medial or lateral, and for a superior inferior aspect of the subluxation presentation. So these are just pictures of how you would challenge for the sphenoid to being posterior on this side and to be anterior on that side. Just a very light challenge, and then you would look at the foot reflex and see what kind of response that you get. The results of the treatment after the adjustment to his cranium, as according to the findings that I found, every single muscle that was a +4 prior to the treatment became a +5 except the transverse abdominis. After he got off the table, I said, "How do you feel?" He said, "Well, I feel different." But as I said, all the muscles had resolved, except for that, had strengthened, except for the transverse abdominis. I called him up the next day just to kind of check on him to see how he's doing. and he said, I feel terrific. I've got no back pain whatsoever, and I've got no knee pain either. So I called him. I said, could you come into the office just so I could take another look at you, see what you're like after 24 hours. At that 24-hour period, I retested all the muscles, retested the same findings that I looked for in the initial exam, and everything that I had found post-treatment was still good 24 hours later. So this was the first time that he had been able to have no back pain and not walk without a limp and have no knee pain all at the same time. Also, his posture presentation still revealed a right hip was low, so there's still, and the left ear was low. So there were still some postural deviations. Everything in his body obviously is not going to be fixed by one cranial adjustment, but we certainly got quite a few changes. Trendelenburg was negative. Arm fossa test was negative. The left-sided pain at L5 spinous had shifted up to L4. So in conclusion, this case report indicates there's little research connecting the cranial dysfunction to low back pain. Dr. Unger has noticed a change in cranial distortion patterns that will cause modifications from putting blocks in the pelvis, which is an interesting study if you get a chance to catch it. He applied blocks and then took pictures of the face and took two left-hand sides of the face before and after, and huge differences in the facial presentation just by the placement of blocks. Chinappi and Getzoff observed the position of the head and lumbar region are intricately linked. Dr. Blum and Dr. Beck found a cranial adjustment improved vision in a patient. And Dr. Fink, German fellow, discussed the functional relationship between craniomandibular system, C-spine, and an SI joint, and noted that by modifying the mandibular joint, then the bite would affect the neck and the low back. So this case study, I think, clearly demonstrates that by correcting the cranium, you can affect the low back pain. So my time is up. Thank you. Yes. Recovered from the surgery. His low back pain came back with a vengeance. It was constant, unremitting, and he was very unhappy, needless to say. He came to my office. As a result, I'd been treating his wife successfully, so he appeared in my office and was at the same time, and still is, receiving physical therapy for his knee to recover from the surgery. Involved in a second altercation with a different person and injured his knee in the process. So from last July until this spring, he had the knee injury. His low back pain began to come back periodically, and he was scheduled for knee surgery. So in March of this year, they had knee surgery on his, I believe, his right knee. And as soon as he, this case report is to examine the clinical connection between lower back pain and cranial disrelationships. Had a patient present to my office. He's a policeman, 39 years old, weighs 275 pounds, 5'9", a little overweight. 3 or 4 years previous to his visit to my office, he had been in an my name is Bill Boro. I'm a chiropractor in Annapolis, Maryland, certified SOT craniopath. Presentation today is treatment of low back pain by cranial adjustment. Let's see if I can figure out this one. Most people, I assume, are familiar with the basic anatomy of the skull. Low back pain is obviously something that, as chiropractors, we treat every day. Altercation with the suspect. He had to subdue him and then lift the man up on a stretcher into an ambulance. And during the process of lifting him up on the stretcher, his low back went out, injured himself, and then received some physical therapy for that. The low back pain resolved itself for the most part. About a year ago, July 2011, he was involved